I started to find it, and I literally couldn't.
Give me just a second. I'm trying to find the slides from our classroom presentation for you for the background check.
Oh,
So I'm trying to load them. Give me a minute. Because I did, we had on the screen was step-by-step instructions with screenshots and everything to walk you through the background check.
Okay. So too, you have this. I know, I'm so funny with like directions and the paper. I'm so bold.
So that's the I think it's so cute. It's so
And then you go down when you're registering the code you're gonna use. And then,
You could put a picture.
so yeah, this is gonna be the,
Really?
and then she said there's gonna be like this.
Oh Lord, I'm gonna buy this right now.
I
should have got
It's
her.
like places
It's so
that you can
cute, and it says her name.
I should have got her drive like.
Oh, let's get another one. Another one.
And then it picks, and then based on the location, it could.
I love that. I think
different
it's so
the price
cute.
of the fingerprints.
I
Like,
didn't
okay, I'm not-
see this one.
And then she said like, if you gotta check your email, takes 2 or 3 days, you check it.
You want her last name?
And then,
Oh my God, I'm never
her
gonna find out what it
application.
is. I'm never gonna know what it is.
I forgot about it. Yeah, you're just gonna go on that website and like pick the place, and then it brings you to whatever, and then you just fill it out, and it tells you. No, because I was waiting on you.
Oh my God. It's crazy.
It's
coming down like 4 leaves.
Like brakes, tires, rims, all that stuff has been getting replaced in my car, so. So I just paid her back, so she said just to do it today, so I'm gonna do it because that means like we're all done, so I'm not waiting 2 weeks. Yeah, if you just follow this, it should be good or something.
Never know when she's on. Oh my. You just really? Yeah, I was like,
She's like, biting the button. She's trying to make things very for the girl world at the same time, to get the, sometimes you need a little technology help.
you know, but I'm sorry. I just moved back into her house. I didn't know I was tired of moving. So.
Okay, this walks you through step by step with screenshots exactly how to do it.
Okay, thank you so much.
You're welcome.
Thank you. Yeah, this one.
Okay. Morning. All right, so over the weekend, oops, let me get my mic here.
Thank you. Oh my God. Yeah, I put on the floor outside. Yeah, I'm sorry. I don't lie about that.
All right, you have chapters 8 and 9 to do over the weekend. Any questions on those two chapters? Any questions? No? Okay, good morning. I'll go ahead and get your scores.
Sorry.
This is for chapter 8 and 9. Kendra?
Yes. What page was it on? 188.
188 and 189.
Okay. 1 second, please.
Sure.
Um, 95 for both.
Thank you. Brittany? Lashadra?
95 for 8 and 85 for 9.
Thank you. Do you have 7 for me?
95.
Thank you. Sahar?
100 for both.
Thank you. Korea?
8, I got 100. 9, I got 95.
Okay, do you have 5, 6, and 7 for me?
5, I got 100. 6, I got 100. 7, I got a 95.
Only one correct.
Thank you. Catherine?
Some don't.
Catherine? Jordan?
I got 100 for both.
Thank you. Megan? Tanaya?
I still need to do it.
Okay. Aaliyah?
95 for 8 and then 100 for 9.
Do you have 7 for me?
100.
Thank you. Ricky?
I got 100 on both.
Thank you. Lori?
Nope.
I'll go to you on Wednesday.
Okay. Nadine? Jasmine?
8 for number chapter 8. Sorry, and I got 90, and then for chapter 9 I got 85.
Okay. And Jamie?
Why? 5
Chapter 8, I got an 85, and chapter 9, I got a 90.
Thank you. Sorry, I can't hear scores.
Okay, sorry.
Okay. Any questions on what you missed? Any questions on anything that you missed? No? All right. So today we have a couple of skills to learn. And we're going to bring in the last range of motion as well, because we still have to learn range of motion shoulder. So we'll go over that at the end. So today it'll be 4 skills. It won't take a ton of time. You should have about an hour of practice time at the end of class today. Maybe a little more or less, depending. But today isn't too bad. You've got all the knowledge necessary. So now we're just applying those skills to those principles to other skills. All right, only one class left. If you've not registered for the test, you probably should. That way it doesn't get too far ahead of you. Remember that your confidence is not going to increase after you leave the class. It's actually going to decrease a little bit the further out you get. So I want you to keep that in mind. Don't not register because you don't think you're ready. You are. Game show, we do live on the 1st and 3rd Tuesday of every month. And I know I've talked about this before, but I have one coming up next week on Tuesday. It'll be after graduation. And it's a game show format. I give out prizes. And it's going to give you 15 practice test questions. So they're going to be written very similar to the way the test writes questions. The answer choices will be very similar. Thought process is going to be very similar. So it's a really good dress rehearsal for the state exam, and you can win prizes as well. So remember, that'll be next Tuesday, a week from tomorrow. So good morning. We talked about this last class, your ideal workplace, the workplace personality quiz. This will help you identify what your ideal workplace is going to be. And it's going to look at a lot of factors. Your personality level, the shift that you prefer working, 8-hour, 12-hour, if you like working in a group with other people, or if you're a little bit more independent and solo, whether you like clinical skills or personal skills. So it's going to go over a lot of things with you that you probably didn't think about when you're thinking about job search. You're more thinking about how close is it to my house, what kind of patients are there, and what's the pay. That's what you're focused on. But your success really isn't going to be dependent on any of those things. So we have to go a little bit deeper, and that's what the quiz is going to help you with. All right, so we're going to get into the first skill today, and this is assisting a resident with a bedpan. This is on page 147 of your book. Okay, so if you look at the principles involved in this particular skill right here, you can see that we already know all of these. We follow the
Care plan.
Yeah, every skill starts with an opening. Every opening starts with Yeah, we're going to evaluate if we need gloves. Spoiler alert, you do. Body fluids. We're going to use a barrier. The barrier is going to be a little bit different for this skill, and I'll explain why in just a minute. We got to make sure the patient's in the middle of the bed, the safe zone. Anything that we clean the same way. We rinse, dry, and store. And we're going to do the closing. So none of this really changes. The two things that I'm going to talk to you a little bit about today is barrier and scoot and roll for this one. If you look at the bottom of the screen, you can see that somebody with your level of experience should be able to do this in 10 minutes or less. Patient's going to be a student. That means one of you will be a patient for the skill. We'll talk about that too. Don't stress. You're going to be in bed. Charting is not required. Of course, I've got a video for this. And this is your Cliff Notes version, short version. But let's look at the care plan here. Care plan on page 148 at the top tells us the resident has requested a bedpan. The resident is not wearing undergarments and is able to wipe self. The resident is able to move as directed. This is super important. Super important. Remember I said that you will be a patient for this skill. You know, somebody like you, a testing student. For the test, you are going to be placed in bed, fully clothed. They're going to put a hospital gown on over your clothing. You're not really going to use the bedpan. They're just going to place it under you and take it out. Okay, pretend D. Good? Make sense? Okay, that's why the care plan says the resident is not wearing undergarments. They don't want somebody to try to take your clothes off during the test. It also says that the resident is able to wipe self. They don't want anybody in that area during the test. So what do we know about the care plan? Follow it. So don't be trying to take people's clothes off for the test and don't get in there to clean. Our patient, according to our care plan, can do those things themselves. And I'm here to tell you that if you try to clean up somebody that can clean themselves, they're going to fight you. And they should fight you. Does that make sense? Good. So you have to understand the parameters for this skill. It is a simulation skill, but you can't really put a mannequin on a bedpan. It doesn't work very well. We need a real person for this skill. You're just not actually going to use the bedpan. Okay. So remember, we have to read the care plan. Now, this care plan goes on to say at the very end, the resident is able to move as directed. That means we can ask them, can you lift your hips? Easiest way to get a bedpan under somebody is if they can lift their hips. If they can't, for whatever reason, and yeah, you're going to have patients that can't, then we scoot them toward us, roll them on their side, and put the bedpan under their butt and roll them back. Okay? So we roll if they can't lift. Good? Make sense? Okay. Thankfully, for the test, our patient can lift. All right, let's talk a little bit about bedpans because they're not what a lot of people think they are. All right. When a patient comes into a clinical setting, they come in with doctor's orders. Okay. And that tells the nurse what the doctor wants and doesn't want. And the nurse is going to develop the care plan that tells the CNA what to do and not do. Everybody understand that flow? All right. So one of the things in the doctor's orders is always how we're going to address toileting. So toileting actually comes from the doctor, not the nurse. So does eating, actually, comes from the doctor, not the nurse. So remember that CNAs can never, ever, ever change a care plan, right? We know that. Well, this is even more important because these are doctor's orders. Think of them as laws. So, and I see this all the time. CNAs will decide that a patient needs a bedside commode and go get one for them. That's not your role. What do you think would happen if a CNA makes that decision?
She's stepping outside of boundaries.
Okay, so we're liable now. We have liability. We are operating outside of our scope of practice. So be very careful with this. It seems like a no-brainer. Well, if she can't get out of bed and there's no orders, I'll just grab a bedpan or a bedside commode, and we can't do that because toileting orders come from the doctor. Everybody got that? So why would this even be about? I mean, why is this a big deal? It's just toileting. It's something we all do all the time. Yeah, there's a lot of things that go into this. So let me lead you through the thought process here, okay? When a patient comes in, the first thing that we look at is, are they continent? Can they hold their urine, basically? If they're not continent, we do pericare every 2 hours. We've learned that, right? Right? Okay. So if they're not continent, pericare every 2 hours, problem solved. We can just stop right there. But if they are continent, if they're able to hold their urine, well, now we've got some bigger problems. We got to look at this a little bit further. First thing we're going to look at is, can they go to the bathroom? If the answer is yes, thank God. Our job is way easier. They're going to go to the bathroom, maybe with or without assistance, certainly. But if they can go to the bathroom, get out of bed and go to the bathroom, it's a normal toileting experience. Everybody is happy with this. We may have to help them. That's fine. Our care plan will tell us that. But if they can't get to the bathroom, then we look at bringing a bathroom to them, a bedside commode. It's what we have over there in the corner, and it looks like a toilet. It's brought to the bedside, and the patient just transfers from bed to bedside commode. But it's still kind of a normal toileting experience, right? They're still sitting on something that feels like a toilet. They're still upright. So it's kind of a normal toileting experience, and CNAs are going to clean that out every time it's used, using our basin cleaning procedures. But if for some reason we don't think that they should be getting out of bed and onto a bedside commode, maybe they're non-weight bearing, maybe they had a stroke and they're paralyzed on one side and physical therapy hasn't worked with them yet, maybe they were just amputated and they don't have anything to work with yet. There's a lot of reasons why a patient might have to stay in bed. Well, just because they have to stay in bed doesn't mean their toileting needs stop. So if they can't go to the bathroom, if they can't get out of bed to use a bedside commode, now we got to look a little bit further. And the first thing that we're going to consider is a catheter. Is a catheter indicated in this case? Now, catheters are not used for convenience. That's important. We're going to get to that in just a little bit. Next skill. Catheters are not used for convenience. Catheters are used if the pee cannot come out on its own, or if the pee comes out at really bad times, like in the middle of surgery. Okay? We don't want you peeing on our sterile field when we're doing surgery. So catheters are used during surgery. If we give a female an epidural during childbirth, we usually use a catheter because we don't want you to pee where baby's being born. Okay. So catheters are sometimes used because peeing is not happening at the right place or time. But most of the time, if the pee can come out on its own, we're not going to use a catheter. I'll explain why in just a few minutes. It's a very high risk with catheters. So now we went through all of that. Bathroom, with or without assist. Bedside commode, with or without assist. Catheter, does the pee come out on its own? And now we're at the end of the list, bedpan. Do you see what I had to go through to get to bedpan?
So it's like your last resort.
It is our last resort. That's right. Now, there's a lot of reasons for this. A lot of reasons. And we're going to go through them. But we need to understand that this is not just a whim. This is an actual pathway that the doctors have to go down to make this decision. So if you as a CNA come along and try to change this up, you're not even operating as a nurse. You are now operating as a doctor, and the state boards do not like that at all. You're way outside your scope of practice. Make sense? Now, the reason that I talk about this a lot is that this is probably the most violated aspect of CNA, because we deal with toileting all day, every day. It's like our number one task is to deal with toileting. So it's really easy to overstep these bounds without realizing it. So that's why we have to spend some time looking at this. So let me go back here for a second. So let me explain to you a little bit about why bedpans are a last resort. You've been trained since you were about this tall, don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. That is absolutely not allowed. Do you remember when we talked about every part of our body ages, including our brain, and our brain is our memory-making factory? You guys remember hearing that? Mm-hmm. Well, memories that you make when you're young stick around a long time because they're made with a brand new factory. So just because you are now trapped in bed does not mean your brain is going to let you go in the bed. Even if we put a plastic pan under you, your brain may go, nope, not going to happen. Does that make sense? So patients will often have a very real problem with physiologically going to the bathroom on a bedpan. Their brain just may not let them do it. Now, on top of that, it's not overly comfortable. It's not painful, but it's not overly comfortable. Okay. The other issue here is that it's just physics. Okay. You've got an undercarriage and you've got the bedpan right under the undercarriage, and there's only about that much space. That's it. Okay. And if your undercarriage sags at all, you'll be in the pee, right? Not comfortable. This can keep patients from going. Does that make sense? Okay. Now, the other problem with this, that's it. That's all the space we have to work with, is that pee, when it comes out, is under pressure. So we have liquid under pressure only traveling this far and hitting a flat plastic surface. You're going to get splashback. This is not comfortable for your patients. Does that make sense? So when you put a bedpan under a patient and you leave them, if they can't go, don't get mad at them. Give it a try yourselves. You'll start to figure out why they can't go all that well. Good? Makes sense? Well, we're going to try again. We'll give them a couple minutes and then we'll give it another try. And after the third try, if they're not able to go, then you can probably let the nurse know. But there's a couple things you can do to make this a little bit easier for your patient to improve our chance of success. Okay. Now, both of these you need to ask the nurse about. You have to get permission. If we are documenting intake and output, you guys remember what that was? Measuring everything that comes in and everything that goes out. If they're on intake and output, we can't do anything about that. We're going to have to just let them pee in the bedpan because we're going to have to measure it. But if they're not on intake, if it's just a regular patient regularly going in the bedpan, we're not measuring anything, then if you take toilet paper and you do big loops of toilet paper, about 4 or 5 big loops of toilet paper, lay it in the bottom of the bedpan, it helps prevent sloshing around, which is important. It absorbs the urine, it prevents splashback, and it kind of helps a little bit with sound as well, because when you're stuck in bed peeing in a bedpan, it's loud. Everybody around knows what you're doing, and that can give you a shy bladder. So it helps with that sound as well. Make sense? Okay, but we have to get permission for that. Can I use toilet paper in the bedpan? If the patient is on I&O, we can't. Now, the other problem with bedpan is that they're shallow. They're only about that deep, and that's the deepest. The shallow end is more like this. It's not going to hold a whole lot. So when we are working with bedpans, it's likely to slosh out. What could we put on the bed that might protect the bed? A barrier, Chuck, sure. Because it's absorbent, it's waterproof, so we're going to put that under the patient, then the bedpan on top of that. So the barrier, we are using a barrier in this situation, but in this case, it's not going to go on the table. It's going to go under the patient. Depends on your facility. Some places will want you to use the disposable. Some places will want you to use the washable, depending on the facility. All right, so the other problem with this, I'm going to come back to this in just a minute. We're going to put a barrier under there. Remember, clean rolls toward.
Pretty rolls away.
Yep. So this is clean. So I'm going to hold it up, roll it toward me, put it under the patient, have them lift their hips, and just unroll it. Super easy. Remember, our patient can move as directed. When we put the bedpan under the patient, the widest part of the bedpan, this part right here that looks like a toilet seat, that goes under the bottom. Don't put it the other way around and have this, it's too wide. It'll have their legs too wide. It's not comfortable. Can you imagine sitting on this? That would be uncomfortable. We want them to sit on the seat. So this is how it goes in. Okay. But notice it's not very wide, deep. It's not much there. Okay. But here's the problem. You can't go lying down. Okay. You simply can't go lying down. And it actually gets worse than that. Bless you. Not only can you not go lying down, this is our patient laying in a bed. When we put a bedpan under them, they're not just lying down. What happened to their middle? Yeah. So we've raised the middle. So not only you can't pee lying down, now you're trying to pee uphill. How successful do you think you're going to be? Now, you think that's hard, try pooping uphill. So the single most important step for this skill is to get our patient in a normal elimination position, and that is sitting up. Okay, so we have to put the head of the bed up. Now they're sitting on the bedpan, pushing it down into the bed. You're not going to get it out from under them unless you put the head of the bed down and ask them to lift their hips to take that bedpan out. Good? Make sense? Everybody good with that? Okay.
So when they're going, you put them up. When you want to get out, you put them down.
Put them down. Yep. So the important steps of this skill really are all about the head of the bed. But if we put a chucks under our patient, do we want to put our hands underneath a bare butt without gloves? No, butt juice. So if we put the chucks underneath the patient and we put the bedpan on top of the chucks, we now have soiled gloves. Do we want to touch that bed controller with soiled gloves? So what should we do before we put the head of the bed up?
Gloves off.
take the gloves off. Yeah, because the patient's going to hit the bed controller at some point later today and then eat their tuna salad sandwich. Don't contaminate it for them. Okay, good. All right, with all of that motion of the head of the bed, up and down, and all of this stuff going on, whatever's in that bedpan is likely to slosh around. So you really want to make sure you get that barrier positioned properly to absorb any urine that comes out. Okay, you guys starting to see why bedpan is last resort?
Yeah, no one wants to use it.
No one wants to use it. And this is where CNAs get in trouble because this is not optimal, right? No CNA wants to deal with bedpans. They would rather get the patient up and take them to the bathroom or get them up and put them on a bedside commode. Are we allowed to make that determination? So we need to be very, very clear on that. Okay. And I've seen a lot of CNAs that do that. They'll just, well, it's no big deal. Just transfer, put her on the bedside commode, not realizing that she has an embolism, a thrombus, a blood clot, and upright moving elevated her heart rate. That blood clot broke free, went to heart, and then the lungs and killed them. Oops. Oops. It's not really something we can oops, right? So what we do matters. And we've got to understand that. All right. So once we get them on the bedpan, get the head of the bed up, it said they can wipe themselves. So what do they need? Yeah, they got to be able to let you know when they're done. So what do they need? Call lights. We're going to give them the essentials. Make sure that they have these things before you leave. Now, for the test, there's nowhere to go. You have no other patients for the test. It's the only time in your career you will have one patient. That's it.
Just turn around.
So, yeah, we're going to go on the other side of the curtain and just wait for them to say, I'm done. Beep, beep. Whatever they're going to say. Okay, just to let us know that they're done. And then we can come back around the curtain. We don't have to wash our hands because we're not leaving our patient, right? But if in a clinical setting, right, not for the test, if we're leaving that patient to do what they, and guys, leave the patient. Seriously, leave the patient because nobody likes to go with an audience. In fact, even better if you can get the, you need help?
I'm just trying to turn it a little bit.
Yeah. Even better if you can, sorry, I just lost. I'm sorry.
You're welcome.
Oh, okay. I'm sorry. Even better if you can take the roommate out. Okay. So they don't have an audience. People are sensitive to the way things sound, right? And that may keep them from going. Or they may be afraid that what they're doing smells and they have a roommate. So if your patient, your roommate has to go for a walk, ambulate with a gait belt, this is a great time to do that. Does that make sense?
For the test, can you just let your other person that you're working with just be like, just let me know whenever you're done, because then you know.
Right. And for the test, the evaluator will tell them. Remember, I said when you're a patient, you're going to get a script. The test is going to tell them to make some sort of a announcement that they're done. Either verbally or they'll be told to say beep, beep to simulate a call light when they're done or something like that. Some sort of notification to you. So, and for the test, we don't have to go anywhere. Don't have to wash our hands. We're just going to stand and wait. In a clinical setting, please don't do that. Go. Take the roommate with you if you can. Give them some privacy to go. But if that call light doesn't go off within about 10 minutes, you probably need to check on your patient. Don't leave them on a bedpan for hours. That actually happened in a nursing home in Pasco County, I think it was, or Pinellas, one of those two. Somebody put a patient on a bedpan and legit, I mean, this was an accident, forgot that they were on the bedpan. You know, I mean, we get busy. Sometimes things slip through the cracks. It was legit. Try not to let that happen to you, okay? But this was a heavier woman sitting on a bedpan, And I think she was nonverbal or something happened where nobody checked on her. So I don't know if she hit the call light, nobody answered it, or she wasn't able to hit the call. I don't know what happened there. But when they got her off of that bedpan, like the next shift found it. And it was like 6 hours that she had been on this bedpan. And remember we talked about pressure, right? So this woman's body weight just kept sinking lower and lower and lower. And the edge of that bedpan kept going higher and higher and higher. And it cut into her skin and caused a huge bed sore. Huge.
Now you have to take care of it.
Right. But even worse, the patient has to deal with that. Right? Make sense? So if you put somebody on a bedpan, try to make a note somewhere, put a mark on your hand, do something to remind yourself that there's a patient on a bedpan. You probably ought to go check on them. A CNA that's working actually told me a really cool thing that she does for this, and I thought it was pretty ingenious. She wears a watch, and it's on a springy band like this. So anytime she puts a patient on a bedpan, she turns her watch over. So if she goes to look at her watch, it reminds her that she's got time. Somebody's on a bedpan. She's got to pay attention to time. Okay. So I thought that was a really good idea, because she can't now see the time because somebody's on the bedpan. So I thought that was a really good way to kind of manage that. Okay. All right. So remember, our patient is able to wipe self, so we're going to give them the essentials before we leave. Now we got to get the bedpan out. They're sitting on it, so we're going to put the head of the bed back down. Do that before you put the gloves on. I mean, it really doesn't matter too much because we're not really touching the patient. We're just pulling the bedpan out. But I just want you to keep in mind the first thing our gloves should touch is the patient. So it kind of follows our rules. Okay. Now, we have to cover this bedpan. You cannot carry an open container of urine through a room. First of all, it's a privacy issue. Nobody needs to see what's in there. Second of all, it's an infection control issue. You don't want to carry open urine somewhere. Third, it's a safety issue because if your shoelaces come untied and you trip and you're holding an open container of urine, do you know where your face is going to go? Yeah. So cover your bedpans, okay? Now, lucky for us, we actually have a chucks underneath the patient. So when we go to take that bedpan out, we're going to take the chucks out too. And we'll just use that chucks to cover the bedpan for transport. So good? Good. We're just going to dispose and take care of our bedpan the way we do everything else. This never changes. You're just going to dump it. Where do we dump it?
The toilet.
Yeah, even though it's pretend urine, there's nothing actually in the bedpan, you're still going to dump that pretend pee in the toilet. And then you're going to rinse it. Where do you think the rinse water should go?
The toilet.
In the toilet. And then we'll set it down, pick it up with a paper towel, dry the inside, dry the outside, and store it. Now, we know where their hands have been. Our care plan told us that they were able to wipe. We know where their hands have been. So we need to give them a hand wipe at the end of this. Okay. Now, I will tell you that I don't touch that hand wipe. I know where their hands have been. So when I'm done taking care of the bedpan and I'm getting ready to give them a hand wipe, I grab a paper towel. So I'll give them the hand wipe, let them wipe their hands. I'll use that hand towel, that paper towel to pick up the hand wipe and throw it all away. I'm not touching that hand wipe. Okay. Now, we still have the privacy blanket on. So we have to wait until after we remove our gloves to take the privacy blanket off. Do you guys remember that? Okay. And then we're going to make sure that they're comfortable. So now it's just the closing after that. So this doesn't really have a lot of difficult steps to it. You're going to do your opening. We're going to put a barrier, or put our gloves on, put a barrier in place, put the bedpan under the barrier, take our gloves off, head of the bed up, give them the call light and toilet paper, ask them to let us know when they're done. When they're done, head of the bed down, put our gloves on, take the bedpan and chucks out, dump the bedpan, clean it, store it, take our gloves off, give them a hand wipe, and then take the privacy blanket away. That's it. It doesn't take 10 minutes for the bedpan. They give you 10, plenty of time, but it doesn't take that long. Now, I want to talk to you a little bit about bedpan cleaners. You actually have a picture of this in your book on page 148, but let me look. Sorry, 146. 146. You have a picture of this. This little thing that looks like a shower head, this is going to be on mostly acute care settings like hospitals, rehabs, that type of thing. It's on the toilet, and it kind of is sticking up like by the pipes. If you bend that forward, you can see like there's a pivot point here. If you bend it forward over the toilet, it starts spraying. It looks like a shower head, like a mini shower head. And that is called a bedpan cleaner. It allows you to clean the bedpan right over the toilet. So you're dumping the contents into the toilet. Very, very convenient to be able to clean bedpans and other soiled items. The problem is that we have water under pressure hitting a flat plastic surface, so we get splashback. And you are in the line of fire. You are in the splash zone. So we want to dress for the job here. I don't want fecal matter on my uniform. So I'm going to put something over my uniform to protect it, like one of those yellow isolation gowns, and then throw it away when I'm done. I also want to protect the holes on my face. So a mask with a shield is a really good option. Now, a word about masks, they do not help with odor. A lot of people try to wear masks to help with odor. It doesn't really do a whole lot to filter odor. So don't rely on your mask for that. It may help a little bit, but not enough. There is something you can do, though. If you go get, we used to use Vicks all the time. You know, the stuff Mom used to put on your chest when you were sick, right? Smells like menthol. Yeah. We used to use that years and years and years ago. You just put a little dab underneath your nose on both sides, and it does help with odor. Well, now essential oils are everywhere. You can get them at every retail store there is. So if you take some Vaseline and put a couple drops of your favorite essential oil in there and mix it up and use that right under your nose, it does the same thing, but it might be a scent that you like better. I personally like orange blossom and lemongrass. Those are my two go-to scents. And it's not uncommon to have odor when you're dealing with, you know, waste products. So that's a really good tip for managing odors. You also can, if the nurse says, remember we have to run this by the nurse, you might be able to spray some air freshener before they go. Okay, because that kind of helps manage the odor. Those little sprays that you can spray into the toilet, that doesn't work because what that does is it creates a film on water. We don't have water on the bedpan. Okay, so that's not going to help you. But a preemptive spray of the room may. All right, so any questions on the bedpan cleaner? Make sure you dress for the job. When you put the bedpan under the patient, we already talked about the position as far as the seat part of the bedpan under the butt. We know that. But you've got to make sure that you're getting it in the right place. And this takes a little bit of practice. Because remember, you're putting the head of the bed up. That bed right here is going to bend right where the bedpan is. If you've got that bedpan too far forward, it's going to slide forward between their legs. They won't be sitting on it. If you've got it too far back, it's going to slide backwards up their back. And it's not going to catch what you need. So this actually takes a little bit of practice. And you want to practice this on real people. So chances are you don't have at home a bedpan and a bed that goes up. So this is something you probably want to practice here with other students before you graduate. Okay? Just to kind of get a sense of where that bedpan should lie. All right, so here are our test-specific checkpoints for this skill. We're going to ask our patient to lift their hips, or you can roll them if they can't. For the test, they can. You're going to put your chucks under their hips. You'll position the bedpan under the patient. Ask if it's comfortable. Raise the head of the bed. I always tell the patient you may have to adjust that bedpan if you need to. Gives them the ability to do that once I put the head of the bed up. Going to give them TP and call light. Lower the head of the bed when they're done. Put our gloves on. Remove our bedpan and chucks. Cover bedpan with chucks for transport. We're going to clean and store that bedpan, remove the gloves, and give the patient a hand wipe. We'll also remove the privacy blanket at the end of the skill. Okay? All right. So let me go ahead and show you this video because it has good close-ups. Camille says, good morning, Patty. I just passed my written and prometric skills. Thank you so much for your videos. It really helped the whole class continue doing your great job. Oh, congratulations. Welcome to healthcare. Great job.
Sorry.
All right, so let's go ahead and look at this video.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I understand you need a bedpan. Can I assist you with that?
Sure.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll need a chucks and a privacy blanket for this skill. Okay, Mr. Jones, I'm going to place this privacy blanket over you. This will help keep you warm and protect your privacy as we do this skill. Is that okay?
Yes.
Okay. I'm going to spread this out without snapping it or shaking it. And I'll have you hold this in place so I can pull your sheet down. That way your sheet remains clean as we do this skill. Okay, I'm going to prepare a chucks to place under you before we put the bedpan in place. I'm going to hold the chucks up lengthwise and roll it toward me. Clean rolls toward me, dirty rolls away. And I'll just place this on the bed. I'm going to open the drawer that the bedpan is in and get a set of gloves. Okay, Mr. Jones, in just a moment, I'm going to ask you to bend your knees, lift your hips as high off the bed as you can, and I'm going to unroll the chucks underneath you. Okay?
Okay.
All right, go ahead and bend your knees and lift up. Okay, and you can relax. I'm going to go around to the other side of the bed and unroll it. Okay, Mr. Jones, can you lift up again, please? I'll smooth the chucks out, making sure it's positioned properly on the bed. You can relax. Okay, now I'll get the bedpan out from in the drawer. And I'm going to place this under your bottom, if I can get you to lift and relax. Is that comfortable?
Yes.
Okay, I'm going to put the head of the bed up, but let me remove my gloves first.
Okay.
Okay, I'm going to put the head of the bed up. Please tell me when you're comfortable.
Okay.
And you may have to adjust that bedpan a little bit as it moves. Tell me when you're comfortable.
That's good.
Okay, here's your toilet paper and your call light. And I'm just going to wait out here. Please let me know when you're done. Okay, Mr. Jones, I understand you're finished. Let me help you with that. I'm going to put the head of the bed down now. And please do not lift your hips. Once the head of the bed is in the lowered position, I'll put on a pair of gloves. And I'm going to hold that bedpan flat as you lift off of it. Okay, Mr. Jones, I'm going to take a corner of the chucks and hold the bedpan flat as you lift off of it. You can go ahead and lift on the count of 3. 1, 2, 3. Thank you. I'll remove both the bedpan and the chucks and take them to the bathroom for disposal. I'll be right back. Once I get over here to the bathroom, I'm going to unwrap the bedpan and we'll throw the chucks away. I'm going to empty the contents of the bedpan into the toilet, and then I'll rinse the bedpan. We'll deposit the rinsed water into the toilet as well. And then we'll set the bedpan down to dry. I'll pick it up with a paper towel. I'm going to dry the inside. We'll throw that paper towel away. I'll dry the outside, throw that paper towel away, and get one for the drawer. Okay, I'm going to place the bedpan in the drawer along with the toilet paper. And we'll use the paper towel to close the drawer. Now I can remove my gloves. Mr. Jones, would you like to wipe your hands? Thank you. Okay, you can relax your legs if you'd like. And I'm going to pull your sheet up and remove the privacy blanket. We want to make sure that we roll the blanket in a ball so that any trailing edges don't contaminate other surfaces. There you go. Here's your call light. I'm going to go put this in dirty linen. I'll be right back. Okay, Mr. Jones, are you comfortable? Is there anything else I can get for you while I'm here? A magazine, perhaps? Your call light is there. Please let me know if there's anything that we can do. I'm going to open your curtain and go wash my hands.
Thank you.
After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right, questions? You see that does not take 10 minutes. Any questions? All right. We're now going to get into catheter care. So today is all about toileting. Good morning, all. On my way to do my clinical exam now. I congratulate myself ahead of time. Thank you, Nurse Pat and your team for preparing me. Oh, good luck. Good luck. We're going to keep everything crossed for you. Come back and let us know how you do, but I know you got this. So, good job. All right. Provide catheter care to a female resident. This is on page 158 of your skills book. Lot of principles to learn here, or to go over here. We're going to follow the care plan. We're going to do our opening, evaluate if we need gloves. You do. We're going to use a barrier, a privacy blanket, linen rules, scoot and roll, washing rules, basin cleaning, and the closing. Wow. Lots and lots and lots of principles for this one. If you look at the bottom of the page, you'll see that somebody with your level of experience should be able to do this within 15 minutes. Do you guys remember pericare?
Yeah.
This is pericare with an extra step.
I hope I don't get either of them.
So, yeah, pericare with an extra step. All right, page 159 gives us our step-by-step instructions. And remember, our supplies are located at the bottom of the screen. So, or at the bottom of the page, so you can actually see what we are going to need for this skill. And like I said, pericare forms the basis of catheter care because we're going to clean the catheter, but we also need to clean the skin around the catheter using that pericare technique. What's different, though, for catheter care is that we're not going to clean the buttocks and we're not going to leave them on a pad at the end of the skill. That's where this changes a little bit. So instead of cleaning the backside, remember for pericare, we had to clean the backside because they were laying on a urine soaked pad. Well, here they're not laying on urine. because the tube is collecting all the urine. Does that make sense? So we don't need to leave them on a pad, and don't use pads if we don't need to. They hold in body heat. That'll make the patient sweat. So we end up with warm, dark, moist. So we don't want to use pads if we don't need them. Okay. All right. So when we clean the catheter and the skin around it for catheter care, we're going to do this about once a shift. That's usually what's ordered in the care plan, once per shift. That doesn't mean that we wouldn't have to do it more often if the care plan tells us to, depending on what's happening with the patient. But usually once a shift. We also want to inspect the bag and the tubing to make sure it's not near the floor and not kinked. So there's a couple of parts here that I want to go over with you. Now, this skill is a little bit intimidating for students because most students don't have a lot of experience with a catheter, and it's vaguely scary. So I want to take all of the fear out of this by going over what catheters are and how they work, because it's really not as scary as people think. So this is the actual catheter, this yellow area. This is the actual catheter. It's nothing more than a straw, a bendy, flexible straw. That's all it is. The tip of it is going to be enclosed, though, rounded, and it's going to have, instead of the tip, if you look at a straw, you know, the top is open. Instead of that, because that would be hard to put in, you know, with the open top. So instead, we close in the top and we put the openings on the sides. That's all we're doing here. But if we put this in the bladder, it lets whatever's in the bladder drain down that tubing and into a collection bag of some sort. So this is the actual catheter. You've got the tip of the catheter that has the holes. You have a balloon that's going to keep it in place. You have the shaft of the catheter that exits the body. And then you've got this where it terminates, the catheter terminates. One of these sides is going to attach to a collection device of some sort. The other is how we fill and empty the balloon. That catheter itself isn't going to do a whole lot. You put it inside a bladder, the urine's going to come out, but it's going to go everywhere. So what we need is something to hold that urine, and that's what a collection device is going to do. There's all different types of bags, but this is considered a bedside drainage bag. It's a little bit larger. It's going to hold a little bit more. So we're going to connect that to the catheter at the port. This is just excess tubing. You've got a bag with markings. We do not use these markings to measure. And we have an emptying port. So these are all of the parts of the catheter and drainage bag. Together, this makes up a closed system. That means that there's nowhere for bacteria to get in by itself. We have to open the system for bacteria to get in. Now, that's going to be a problem, and this is why catheters are dangerous. We're going to go into that in a minute. The catheter and the bag are two separate pieces, and that's because we change them at different times. Catheters can actually stay in place for up to 30 days. When a catheter is put in, it doesn't have to be changed for 30 days. Bags, the thing that holds the urine, we usually change those about once a week.
Unless it's filled before that.
Well, if it's filled, we're going to empty it. We actually empty it through this port. So we're going to empty the urine, measure it if we need to, get rid of the urine, and now that bag can be refilled again. But it's going to be changed out every week, usually. Now, there are situations where that may not be the case. Sometimes there's patients that have long-term catheters that live at home, and they may have home health that come in and help them with certain things. These bags are expensive. It's like $30 to $40 a bag for individuals that are buying them. So some patients can't afford, because they have to pay for that out of their own pocket. Some patients can't afford to spend that amount of money to change that every week. So you may see some differences there. Okay, good. So what are CNAs responsible for? Well, we clean the catheter. We clean the skin around the catheter. We empty the drainage bag and we document. That's what we do. Those are our tasks. Clean the catheter, clean the skin around it, empty the urine from the bag, and document that urine. We can be trained to do additional tasks, but not right out of the gate. That would need to be on a case-by-case basis, determined by your nurse and the place you work. Okay? So CNAs can be trained to put catheters in, to take catheters out, to do other things, but that would require additional training, not CNA right out of the gate. Make sense? Okay. So let's talk about infection control again. Now, we talked about this early in the program, like class 2. We learned that no pathogen, no problem. But if we have a pathogen, they don't live well outside of a host. They have to have somewhere to live. So where they live is called the host or the reservoir. Good? Makes sense? And this is in your book as well. But once they're in that reservoir, they're happy. They don't just break out of the skin. They have to have a doorway out. What are some doorways?
Eyes, ears, mouth, nose,
Okay.
anal area.
Yeah, anal area. Wounds. Rashes. Sores.
Anything.
Incisions. Any break in the skin. Anywhere where the skin is not intact. Right? Once they get out, they have to have a way of moving around. Remember, pathogens don't have feet. They don't have wings. They can't fly about on their own. So they have to have a way of moving around. Most are going to travel in body fluids like blood or urine, or on dust particles or liquid particles when you cough, sneeze, laugh, that type of thing. So it depends on the pathogen as to which transportation they prefer. Once they get out of the body and travel where they're going to go, however they're going to do that, then they have to find a way in to another person, right? And then that person has to be susceptible. If all of that happens, now we've got a new pathogen and a new host. We have a new infected person. There's a lot of steps there that have to be met. Good. That's important because catheters pose a very significant risk to patients. If we don't understand this, we don't understand the risk. So Blossom says bacteria are safe at what weather condition? Warm, dark, and or cold. Okay, it's not that they're safe. It's the ideal environment for them to thrive. And warm, dark, moist is what we need to be looking for. Any area that is warm, dark, and moist is at risk for bacterial proliferation. Doesn't mean that they can't survive in the cold. Some do. Some bacteria survive very nicely in the cold, but those are extremes. We're talking about the run-of-the-mill peanut butter and jelly variety of pathogens. All right, so let's review the urinary system. We learned this last week. We have 2 kidneys. Those kidneys filter blood 24 hours a day and produce urine. That urine falls down tubes called ureters into the bladder. Does this look familiar? We have a valve at the bottom of the bladder that holds it closed, allows the urine to build up until it's full. We go to the bathroom, the valve opens, the urine comes out. We're empty again and ready to go for a few more hours. So when we have a catheter, all of that still works. Nothing has changed. What we're doing is using this tube to hold that valve open. That's all we're doing. That's all a catheter does. It uses this tube to hold that valve open. And then the urine is going to fall through these holes into the catheter and out of the body. Okay? That's all a catheter is. This tube is already there. You pee through it every day. We're not drilling, right? It's a hole that's already there. It's like putting an earring through a pierced ear. The hole is already there. We're just inserting a tube to hold that valve open and collect that urine.
I'm ready to change someone's catheter right now.
Yeah, we don't change catheters. We clean them.
I'm ready to clean one right now.
So because urine is going to flow, because we're holding that valve open, urine's going to flow freely out of the bladder. Now we need something to collect it. Otherwise, we're going to end up with a big mess, a urine mess. So that's what the bag does. That's all the bag does, is hold the urine that's coming out of the bladder because we're holding the valve open. So two pieces to this. We have a catheter that holds the valve open. We have a bag that collects the urine to keep it from going everywhere. It's a couple different types of bags. We'll get into that in just a few minutes. We have, we're going to get into it now, I guess. Okay. So there's different types of drainage bags from small to large. Large is going to be what you find in a clinical setting. It's going to hang on the side of the bed. It's going to hold a lot of urine. We usually only empty it once a shift. So big for bed. Big for bed. But if we got somebody that has a catheter and they're up, mobile, walking around, maybe going to the store, the grocery store, or Busch Gardens. And yes, there are people with catheters that continue to lead a normal life. You have no idea they have a catheter. We have quite a few of them, actually, right in our county. You would never know. Just because you have a catheter doesn't mean that you are impaired in some way. Okay. So if we have somebody that has a catheter and is out mobile, we don't want to be carrying a bag of urine with us, right? Suitcase of urine tends to collect a little bit of stairs. It's unusual. So in that case, we would use a leg bag. This attaches to the catheter just like this one does. See how same port, same hole on the catheter, attaches just like, but it's smaller. And it has elastic bands that let you attach it to the inside of the thigh or the inside of the calf. And it's going to collect urine, just like the big bag. But you'll never see it because it's under the patient's clothing. Make sense? So leg bags, they're not going to hold as much. So they would need to be emptied a little bit more. Where the bedside bags, remember big bedside bags are usually emptied out once a shift. So it's like 12 hours. These would have to be emptied a little bit more often, like as often as you go to the bathroom. Okay.
That kind of sucks.
Same with the other bag for like the poop one.
Okay, you're talking about an ostomy.
Yeah, that was it.
Ostomy is going to be covered in your reading. We're not going to really talk about ostomies too much here, just because it's not on the state exam.
Yeah.
But your yellow book had a whole section on ostomies, and that we would just empty and clean when needed.
Mm-hmm.
When needed.
I forgot about that.
Okay. So we're going to use a leg bag most often if the patient is ambulatory or out and about. So here's what makes catheters risky. Okay. Remember I said it's a closed system. There's nowhere for pathogens to get in unless we let them in. Well, if we let a pathogen in, oh, it's game on now. Because inside this bag is urine. Urine has proteins and enzymes that pathogens need to procreate. So it's warm. Urine is warm. It's moist, wet. It's not dark. So that's the only thing that they're missing. But it also has enzymes and proteins they need. So pathogens find this a pretty cool place to live. If we let pathogens into this space, they're going to multiply. And when they multiply, they start to climb. Now that gets them fresher urine. So they multiply faster and they keep climbing. And that gets them fresher urine. And once they get into the catheter itself, now we've got dark on board. Warm, dark, moist, protein, enzymes. It is nirvana. It is where they want to be. So they really ramp up production. And by the time they jump out of the hole, which is in the bladder, remember, it's not 1 or 2 pathogens that are jumping out. It's 1 or 2 trillion pathogens that invade all at once. This is an overwhelming infection that seems to come out of nowhere. It just shows up. Well, it really didn't come out of nowhere. This was brewing in the bag and in the tubing and in the catheter. It's just once it gets to the bladder, there's no stopping it because there's so many pathogens at play. Good? Make sense? Well, the only way that that can happen is if we allow pathogens in. Remember, it's a closed system. If we allow pathogens in, this can be very bad. So there's 3 places that can happen. This is the most common. Remember I said that we're going to empty the bag, right? We have to empty it through this port. If we let that port touch anything, a pathogen will get in. That pathogen becomes 2. Because pathogens don't need little boy pathogens and little girl pathogens to have baby pathogens. They just need the right conditions and they zip themselves in half and now there's 2. Those 2 become 4. Those 4 become 8. Those 8 become 16, 32, 64, 128, and so on. Okay.
You said earlier that we don't use the measurements on the bag when it comes to documenting.
Right. Because it depends on how the bag is situated. If it's crinkled on one end, it's not a accurate measurement.
Gotcha. Okay.
So I'm going to show you how to measure in just a few minutes, but we don't use the measurements on. It's good to eyeball, but nothing else,
Okay.
not for actual measurements.
Yeah. Okay.
All right, so this is the most common place, and this affects us because we're the ones emptying the bag. So when we're emptying the urinary drainage bag, it's super important that that port doesn't touch anything. Not your gloves, not the cup, not the bed, not the chucks, nothing. That's our responsibility. Now, the other place that pathogens can enter is up here, where the catheter and the bag join. Remember I said the bag is usually changed about every week, right? And the catheter stays in for up to 30 days. That means that this is going to be separated from time to time as we take an old bag off and put a new bag on. This is why it requires training. This is not something you do without training, because we want to make sure that we're not introducing pathogens. Because guys, as bad as it was for pathogens to get in here, it took a while to multiply and climb. If we let them in here,
It's going automatically.
This is warm, dark, moist right out of the gate. Enzymes, proteins right out of the gate. So they are able to climb this small area like that and multiply all along that way. So it's really, really dangerous. That's why you have to have additional training to change the bags out. Now, the third place that we can introduce pathogens is when a catheter is put in. And that's up to the nurse. That's sterile technique. We can't do much about that. These 2 are the ones that we are responsible for. Okay? Questions?
So that's most likely how someone who has a catheter would get a UTI.
Correct. You connecting some dots?
I'm connecting a lot of dots, yes.
Yeah, that's the dangerous part about this class. All right, so bedside drainage bags must hang from a non-moving part of the bed. Well, that makes sense. You don't want a part of the bed that's moving and pulls that catheter, right? So non-moving part of the bed. And they have to hang above the floor. We don't want that bag to touch the floor. Remember, floors are not clean places. And if we let the bag touch the floor, they can climb up the port and get in. It's not like sealed, right? Inside the port, there's a little valve that opens and closes, and bacteria can sneak past. So we don't want that bag anywhere near the floor. Drainage bags are also called catheter bags, by the way. You'll hear both. Drainage bags and catheter bags. We also don't want to raise the drainage bag above the patient's hips. Guys, urine really should be a one-way trip. If you raise it above the level of the patient's hips, that urine is going to go right back into the patient along with any pathogens that are hanging out in the catheter.
I was going to say that can cause infection too.
Absolutely. And it's recycled urine.
Yeah.
I don't know about you, but that's pretty high on my gross meter. Pretty high on my gross meter. Urine should be a one-way trip.
Can you feel it can the patient feel it if their pee goes back in them?
I don't know. I honestly don't know. I wouldn't want to find out. I wouldn't want to find out. Possibly, but the bladder really only has two types of nerves. Okay, remember, nerves are what connects to the brain and talks to the brain. So bladders, they're kind of dumb organs. They only have two words to talk to the brain with: pee and pain. That's it. That's all the bladder can say. So if something is going on down there, it's usually pee, right? 99999 times out of a million, it's going to be pee. So they're stretch sensors. So I don't know that we would actually feel the rush of urine coming in, but you might feel that stretch. Now
I know you don't feel it coming out when you have a catheter and you don't feel it at all.
Yeah. So the other sensation that your bladder has is pain. And that, we can interpret that when we have a UTI. You get that urgency, frequency, burning type thing. Well, urgency and frequency is all for the pee sense, and pain is that burning that we feel, right? So it's really the only two words that our bladder has to talk to our brain: pee and pain. That's going to be important in just a minute. Sometimes confused patients will pull catheters. This is not uncommon. They'll tug on a catheter because they're confused. It doesn't belong. Catheters should not hurt. They're not comfortable, but they shouldn't hurt. So confused patients will often tug on it because it doesn't belong. Now, if they tug hard enough, they'll pull that right out. Couple things. Your patient is fine. They're not going to die. Don't panic. A lot of CNAs will go running down the hall panicking. It's fine. It's fine. But you're going to see a little bit of blood because we have a balloon this big going through an opening this big. That you're going to get some tissue tearing. You're going to see a little blood. Your patient will heal. It's fine. But they're going to take their cues from you. If you get all, oh my God, what did you do? They're going to start to freak out thinking that they're about to die. So be calm about this. You want to, what we're going to do if a patient pulls a catheter out, let me go here. If a catheter gets pulled out, we're going to put it in a bag, like a trash bag. And we have to save it. Now, the reason that we're saving it is because if a catheter comes out, as a nurse, I have to inspect the catheter. Because a catheter that comes out, but all of it comes out, that's okay. That's something I can deal with. But a catheter that comes out and the balloon is not intact. Okay, the balloon is broken like this. I'm going to pass this around. Has a hole. That means a piece of this is somewhere in that patient. The only way for me to know as the nurse, the only way for me to know is to look at the balloon. Is it intact? No pieces were left behind. Is there a hole? We have a piece left behind. This requires a call to the surgeon. Not the doctor, the surgeon. Because we're going fishing. We have to go find that piece in the bladder. Otherwise, the patient will reject it. It's foreign.
Has that ever happened to you?
Not to me now, thankfully. But it does happen.
Yeah.
It does happen. So When a catheter comes out, you put the whole thing in an empty trash bag in the bathroom so the nurse can, take a look at it so that when they're documenting, they document the right thing. So I'm going to pass these two around so you guys can see what a catheter looks like with a hole and what one looks like that's got an intact balloon.
So Miss Patty, you want one with the balloon?
What of that one?
No, you're saying,
What's that?
what about the one with the balloon? You said that one.
We're going to get there. Hold on one second. I just want to get a new catheter to show you guys. Okay. Because that one's a little bit old. All right. Remember I said that we do not put catheters in and we don't take them out. Who does that?
The nurse.
The nurse. So let me show you what this process is because I think it helps reduce some of your discomfort with catheters if you understand what they are and how they're used. So as bad as this is, right? Patients pulling out catheters, it's actually not as common as you would think. What's more common is us. As a CNA, if that tubing is coiled near the floor, your foot will get caught in it and you will pull that catheter out. Transferring out of bed and into a wheelchair, if you don't move that catheter, you will pull it out. Ambulate with a gait belt. If you don't make sure that the patient doesn't have a catheter before you start walking them and that catheter bag stays on the bed or on the chair, you will pull it out. Now, again, your patient isn't going to die. Everything is fine here. But you need to let the nurse know. Don't hide this. Because anytime we have injury, remember, this is going to cause injury. We have a balloon that big going through a space that big. I mean, you're going to have injury. Anytime there's injury, there's always swelling. This is not a place where we want swelling. That complicates things. How does urine come out if it's swollen? So that complicates things. I also can't put another catheter in if it's swollen. So yeah, I've got to change the whole care plan. I've got about 45 minutes before swelling takes effect. So if you have a catheter that comes out, whether you did it, the patient did it, somebody else did it, I don't care. If a catheter comes out and you don't come let me know for me to have time to make a plan, if you go to lunch and then come back, oh yeah, by the way, Mary's catheter came out, I now have no options. And what do you think that's going to feel like for the patient to try to pee through that torn tissue?
Hurting, uncomfortable.
Oh, yeah, absolutely. So we have to work together here. That I have experienced. I've had several CNAs that patients have pulled catheters out or they pulled them out, or it doesn't matter. There's no blame game here, but the CNA never told me. They hid it. And that happens a lot. CNAs will like leave it in the bed for the next shift to find because they don't want to deal with it. Who's paying the price for that? The patient. That's bad. Let's not do that. All right. So let me explain to you how a catheter. Okay, let me go back here. Let me go back here. So let me show you how a catheter works. Okay. So remember, we have the bladder and we have a valve. When the nurse puts a catheter in, it looks like this. There's no bubble. Do you see? No bubble. This is what a catheter looks like when it goes in. It's lubricated. But we want it to have a pretty snug fit. If I put this catheter in this urethra, you see how much space I got around? I'm holding that valve open. So that means that whatever urine is in in the bladder is going to come out around the catheter. We're going to get leaking. We don't want leaking. That's the whole point of a catheter, right? So we want to make sure that the catheter is wide enough to fit snugly in this space so we don't have leakage. Make sense? Good? All right. So when that's the nurse is going to figure out what size we need. This is 16. It's used by most people. So when this gets inserted into the urethra, we're going to go up until we start to get urine out. If urine comes through these holes and down through the catheter, I know I'm in the right space. So we're going to go up until no urine, no urine, no urine. I get a little urine. Now I'm going to keep going about another inch to make sure the catheter is inside the bladder. And if I let go of the catheter right now, that's exactly what it's going to do. It's going to fall out. There's nothing to keep it there. It's going to slide right out. So we have to have a way of keeping this in place once we get it in the right location. So we're going to insert, 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 insert. A little bit of urine comes out. We're going to go up another inch. And then we're going to blow up that balloon with some water. And when we blow up that balloon, you see the balloon is in the bladder? You can't feel that. It's in the bladder. The bladder is a hollow organ. You can't feel that. It's going to come back down and just sit right there on top of that valve.
Like a bobber.
Exactly. It's a bobber. This is going to keep it from coming out. Doesn't mean it can't be pulled out. This is a squishy.
So when it's in, you can't really feel it.
What's that?
When it's in, you can't really feel it.
So you're not feeling this part. This is inside the bladder. What you're feeling is this. Remember I said it has to be snug. Good? It's got to be snug. And that's what you feel when you have a catheter in. Now, when we put a catheter in, I told you the bladder is a dumb organ, right? Has only two types of nerves, pain and pee. When we put this into the bladder, we put it in and we inflate that balloon. Because we're keeping the bladder small, it's not going to expand with urine. All the urine's going to come out. Because the bladder is small, the top of the bladder is going to hit the top of the catheter because it's shrunk down. Make sense? This hitting the top of the bladder, the brain has to know about it. But your body only has two words. Your bladder only has two words. So it's not really pain. So what do you think your bladder is going to tell your brain? I got to pee, because the only thing it's ever hit the top of the bladder is
Urine.
Yeah. So when we have a catheter in, a lot of times your patients will say, I feel like I have to pee. I got to pee. I got to pee. And a lot of healthcare workers will say, just go. Well, there is no going, because they're not going to bear down, right? That pee feeling is normal. It actually goes away after about 8 or 12 hours because the body kind of gets used to it. But during that 8 to 12 hours, it can be highly annoying. So if you tell your patient, yeah, that's normal, it's just your bladder trying to tell your body something's there, right? So watch a movie, read a book, crossword puzzle, distract yourself as much as possible. That sensation does go away. Now, pain is different. If your patient says, ow, it hurts, you need to let the nurse know right away. Because if that nurse, when she's putting the catheter in, does not advance it enough, and that balloon is blown up here,
Ow.
what kind of pain do you think that's going to cause?
Yeah, a lot.
Okay, so pain is always reported to the nurse. Pee, normal. Still reported, but normal. Okay. The other reason that pain needs to be reported is there's a certain percentage of people that Anybody ever have a Charlie horse in your leg?
Yes.
How bad does that hurt?
Every single night, I'll be feeling.
Yeah, it really hurts, doesn't it? Well, there are some people that when we put a catheter in the bladder, it says, hey, you don't belong, and it spasms to try to push that catheter out. That's actually called a bladder spasm, and it is a Charlie horse of the bladder, and it hurts. So if your patient says, ow, this hurts, believe them. Something is wrong, and we've got to fix it. Don't ignore that. Don't tell your patient it's fine, you'll be fine, everything is fine. No. Pain is never normal. Okay. Any questions on that? Okay. So always be aware, make sure there's no tubing coil near the floor. Make sure that your patient, if they have a catheter, it moves with the patient. And always make sure that we're saving catheters if they get pulled out. So let's talk about the types of catheters that we'll be working with. What I showed you is an indwelling catheter, a Foley catheter. This is a Foley catheter. Remember, in healthcare, everything has two names, right? So this is an indwelling catheter, means we put it in, we leave it in for a certain amount of time. Up to how many days? 30 days. It's indwelling because it has a balloon to hold it above that valve. That balloon is a doorstop. It just holds it in place. If we're going to take the catheter out, we don't just pull it out. We're going to deflate that balloon. And when we deflate the balloon, it just falls up. Okay. Don't ever try to take catheter out without deflating the balloon. That would hurt. We don't want to do that. Remember, you have to have additional training to put catheters in or take them out. So this is indwelling, also called a Foley, has a balloon to keep it in place. But sometimes we don't need to keep the catheter in place. We need it temporary. Quick. I got a full bladder. I need to get it unfull. Quick. But I don't want to leave the catheter there. This is a single time use. It's called a Red Robinson. It's red. Guy who made it, its name is Robinson. Okay. We also call it a straight cath. It has no balloon. It just goes in, empties the bladder, comes out. Well, that means all the urine is going to come right through this hole. That's not going to help us a bit. So we need to connect this to a drainage bag of some sort. All catheters are going to be connected to a drainage bag to collect the urine that we're letting free. Good. We have a third type of catheter called a Texas cath. This one has three names. An external cath or a condom cath because it looks like a condom. This is called external because it doesn't go inside the body. It goes on, this is for males, goes on the shaft. It has a little port here that we're going to attach the drainage bag to. This is going to funnel all the urine out through the tube and into a bag. Okay, so nothing internal, it's all external. These can be left on for up to 3 days. The problem with this, it's very, very helpful, especially with dementia men, very helpful, or incontinent men. The problem with it is that when you put this on, it goes on, it's very sticky inside, goes on like a catheter. It's going to stay in place for 3 days. But this area right here, where the tip of the penis goes, urine is going to be held right up against that area, that urethra, for up to 3 days. Remember, adult urine is very acidic. So when we take an external catheter off, we've really got to do good skin care here. And there's usually a barrier wipe that we'll put on that kind of creates a barrier to help keep that skin intact. So this is convenient, but not without its risks.
Is it different for uncircumcised men?
No, actually it's not. We're just going to retract the foreskin. Let me put this on. All right, so catheter care. Do you guys remember what we learned for Pericare, the leaves method? All right, so with catheter care, we're going to do the exact same thing. I've got my washcloth held in a diamond in between my thumb and pinky, just like this. I'm going to hold that catheter up out of the way. I'm going to go once down the middle, fold that over. Once down the outside, fold that over. Once down the other outside, fold that over. Skin fold and skin fold. Whatever we wash, we rinse the exact same way. I'm also going to clean the catheter itself using the leaves method, new washcloth. I'm going to hold the catheter where it exits the body. Okay, where it exits the body. Wrap the washcloth around and wipe away from the urethra. Remember, everything is always away from the urethra. I'll fold that over. I'm going to do it again. Fold that over. Do it again. Fold that over and do it again. Okay, so we're going to clean the catheter and the skin around the catheter. Remember that's always away from the urethra. And even though there's a balloon holding this catheter inside the bladder, we don't want to be tugging on it. So we want to provide some support where it enters the body as we're cleaning down the length of the catheter so that we don't accidentally tug on it. Okay. All right. So our care plan tells us to provide catheter care with soap and water to a female resident with an indwelling urinary catheter. That's the one with the bubble. Clean the catheter tubing and perineal area only. So this is exactly what we're going to do. Not a hard skill. You already know this skill. You just didn't know the catheter part. Do you guys feel a little bit more comfortable with catheters now? They're a little less scary. A little less scary. All right. So here's the steps. I'm going to walk you through catheter care step by step. We're going to learn about drainage bags, and then I'm going to show you both of those videos, one right after the other. Okay. So for catheter care, we're going to start with the opening. We're going to put a barrier on the table, get our supplies. We'll put a privacy blanket over the patient. We're going to fill our basin with what kind of water?
Warm.
Who's going to check it?
Patient.
Okay. We need some gloves. First thing your gloves should touch is the patient. We're going to turn the patient onto their side and put a chucks under them to protect the bed while we're cleaning. At the end of the skill, we're going to take that chucks away. We're going to roll the blanket like we did for Pericare, just to expose what we're working on. Put a towel over the legs to minimize exposure. And then, and then we're going to wash. Remember to bring your washcloths out thoroughly. We're going to use the leaves method. We'll apply soap to all 5 leaves, hold the catheter in place, and we're going to go down the middle, side, side, skin fold, skin fold. We're going to rinse down the middle, side, side, skin fold, skin fold. And then we're going to dry top to bottom. Good? Questions? We'll ring those sorry. Where did it go? Where am I? Okay, whatever we wash, we rinse the same way. Then we're going to remove the towel and cover with the blanket. My on sign isn't on here. Okay, we'll remove the towel and cover with the blanket. We'll remove the chucks after we clean. And then we're going to put the patient on their back in the center of the bed, covered with the blanket. We still have to put all of our supplies away. Those supplies are definitely not clean. We need gloves for that. But the patient needs to be covered while we do that. So we're going to dispose of all of our supplies in our soiled linens. We're going to clean our basin, dry it, and store it like we do everything else. And then we can remove our gloves. After that, we'll remove the blanket by pulling the sheet up, and we'll do our closing. That's catheter care. Questions on catheter care? All right,
I'm sorry.
Go ahead.
Do you dry the tubing as well?
Just the catheter.
Okay.
Because we're not actually washing the tubing. We're only going to wash the catheter itself.
Right. Okay.
And we only have to go down about 3 or 4 inches. I go all the way to the port just because I'm there. All right. So let's go to drainage bag. I'm going to explain this really quickly, and I'm going to show you those 2 skills back to back, the videos, because they really do go together. Remember, catheter care is done once a shift. Emptying the drainage bag will be done once a shift. We usually do them at the same time, but not for the test. For the test, this is going to count as 2 separate skills. Okay. Good. All right, so drainage bag, there's still a lot of principles here. We're going to follow the care plan. We're going to do our opening, wear gloves, use a barrier, clean our basin, and do the closing. So nothing earth-shattering here, not a whole lot to actually learn. Our care plan at the top of page 165 tells us to empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the intake and output form. Can we use ounces? Why? Easy answer.
Care plan.
Care plan says, yep, very good. All right. We talked about this just a few minutes ago. There's 2 different types of bags. There's a bedside bag and a leg bag. They're both emptied the same way. You want to prevent them from touching anything. When emptying the drainage bag, we're going to put a graduate container on a barrier on the floor. Don't forget the barrier. You don't want to set a urine container right on the floor. We need a barrier. Okay. When we empty the drainage bag, don't let anything touch that drainage port. Not the container, not your gloves, nothing. Nothing touches that port ever. The bag that we're going to use, there's a lot of different types of bags out there. The one that they're using at the test, the one that we use in this class, is this type of a bag. This is just a standard bedside drainage bag. This is our emptying port here. See how it has a little house that it lives in to keep it up? When we remove this from its house, this is the part that we can't touch. We don't ever touch anything below the T-valve. To open it, we simply slide the T-valve to the side. To close it, we slide it the other way. And then we put it back up in its little house without touching anything. So I don't want to do this. So I'll pass this around so you guys can see and practice that T-valve. So to open a T-valve, we're going to slide the button to the side, and after we empty it, we'll close it again. Remember, you have to close it, otherwise bacteria have a straight shot into the bag. What happened here? Okay, don't let the tip of the port touch anything. That's the big thing here. When we empty this into our graduate container, this is a graduate container. When we empty this into the graduate container, there's 3 criteria that must be met for the test for successful accuracy. This needs to be on a barrier, on a flat surface, and we have to measure it at eye level. Now, here's the thing. Those 3 criteria are all on the same checkpoint. On a barrier, on a flat surface, at eye level. So if you don't get one of those, if you don't use a barrier, you actually missed all 3 because it's on the same check point. So you got to make sure that you're following this exactly. On a barrier, on a flat surface, at eye level. So for our purposes, we're going to use the lid of the toilet. Because it's eye level. Yeah, the floor is not eye level. No. And then we're going to document on the output section of the documentation form. So we're going to put the time. Now, you don't have to use military time for the test, but you should. Most facilities are using military time. If you don't know military time, I have a lesson in the book on it. So you should go through the lesson. But military time is this simple. It really is simple. How many hours in a day?
24.
So who's the numbskull that decided to count to 12 and then start over? I mean, no, in reality, that's what we do. We go to 12 and then we go, oh, we can't count any more than that. Let's go back to 1. It makes no sense. Military time, there's 24 hours. We're going to use all 24. So instead of going back to 1 after 12, we just keep going. 13 and 14 and 15 and 16. That's all military time is. And once you understand that, it actually becomes a little easier. Okay. But I have a whole lesson in your book on it. If you use regular time, like now, if I were emptying a drainage bag and I said 10:45, I would need to put AM behind it if you're using regular time. AM. If you're using military time, you don't have to do that because there is no AM or PM. Make sense? So what's the difference? So 10:45 AM, 10:45 military time. You're saying it the same way. The difference is regular time is going to have a colon. Military time will not. So if you put a colon, you have to put AM or PM. You also have to indicate what type of output. Urine. Well, that kind of seems pretty, self-explanatory, but urine is not the only thing that can come out of the human body. Vomit, blood, feces, wound drainage, spinal fluid. I mean, sputum. There's lots of stuff that can come out of the human body. So it's not self-evident. You have to indicate what kind of output it is. And then how many cc's, and then your initials.
You said for the exam, you should use military, but if you don't,
You have to indicate AM or PM.
okay.
Yeah. So ultimately, we're going to follow the care plan. Okay. So our steps here, we're going to do our opening, place our barrier on the floor, get our supplies. We're going to put our gloves on. We're going to empty the urine from the bag, making sure that port doesn't touch anything. We'll close the valve, put it back in its house, wrap the urine container in a chucks, just like we did with bedpan. We don't carry an open container of urine through a room. Once we get to the bathroom, we'll set it down on the lid of the toilet and we document. We'll empty the contents into the toilet and dispose of the rinse water in the toilet, and then store our container. Remove our gloves, do our closing, and document. Finally, wash your hands again. Okay. Questions? Questions? All right, I'm going to show you these 2 skills, the videos back to back, and then we'll learn range of motion shoulder, which is literally a 2-minute skill. Makes this stuff look hard. And then you will have the rest of class today to practice. Okay. I'm going to print off your review sheets as well. Okay, first video we're going to see is catheter care. Jones, my name is Patty. I'm your CNA today. How are you? Good. I need to do catheter care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, Miss Jones, I'm going to gather my supplies. I'll start out with a barrier that provides a clean place to put my supplies. And we're going to get 4 washcloths, a towel, a chucks, a privacy blanket, and now I'll gather my basin and soap. And a set of gloves. All right, Miss Jones, I'll just get some water. I'll be right back. Okay, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place the washcloths in there to stay warm. And I'm going to cover you with a privacy blanket. This is going to help protect your privacy and keep you warm while we do this skill. And I'm going to pull your sheet down to about your knees. Okay, Ms. Jones, I'm going to place this pad underneath you. This is going to help keep your bed dry while we do this skill. First, I'll roll it toward me. And place it on the bed. And then I'll put my gloves on. All right, Ms. Jones, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. I'm going to be very careful, making sure that the catheter tubing rolls with the patient and doesn't get pulled on. I'm going to unroll the chucks underneath the patient's hip and have the patient come back onto their back, making sure that they don't lay on that catheter tubing. Ms. Jones, can you scoot to the middle of the bed, please? Thank you. Ms. Jones, can you scoot toward me? Thank you. And roll up onto your right side. 1, 2, 3. And now I can unroll the chucks to protect the bed. Come on back, Ms. Jones. And scoot to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or stress on that catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take the first washcloth and wring it out and apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to hold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whenever we wash, we must rinse. So I'll wring this washcloth out, and we'll use it to rinse that catheter the same way we washed. I'm going to hold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do peri-care. We'll take a washcloth out of the basin, wring it out really well, and we're going to soap 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my pinky and hold the labia open while I clean down the center with the first leaf, always going top to bottom. And then we'll remove the washcloth and fold that leaf over. Now I'm going to clean down one side of the labia, top to bottom, fold that leaf over, clean down the other side of the labia, top to bottom, fold that leaf over. I'm going to clean the skin fold between the groin and the leg, fold that leaf over, and clean the other skin fold between the groin and the leg, and then set that washcloth aside. I'm going to take the final washcloth and wring it out really well, and we're going to rinse all of those areas the same way that we washed them. So I'll hold that catheter out of the way and spread the labia open, cleaning down the center, top to bottom. Fold that leaf over, clean down one side of the labia, fold that leaf over, rinse down the other side of the labia, fold that leaf over. We're going to rinse the skin fold, fold that leaf over, and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom and then removing the towel. Ms. Jones, I'm going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor and not where the patient is laying on it, making sure it's not kinked. Ms. Jones, I'll be right back. I need to dispose of your supplies. The towels and washcloth will be placed in dirty linen. The basin is going to be cleaned the way we clean everything else. We'll return the basin to the drawer, and on the way we'll pick up the soap. We'll open the drawer with the paper towel and return the basin to its storage area. Now I'll dispose of my paper towels. Okay, Ms. Jones, I need to remove the chucks from under you. Can I get you to scoot toward me, please? Thank you. And can I get you to roll up on your left side? 1, 2, 3. Thank you. I'll roll this soiled chucks toward the patient and tuck it under her hip. Come on back, Ms. Jones. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Ms. Jones, can you scoot toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that chucks from the bed. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Ms. Jones, let me just look at your catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the chucks from the table, and we're going to throw this away, and then I'll remove my gloves. We'll throw those away. Okay, Ms. Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Ms. Jones, here's your call light. If you should need anything, just let me know. Are you comfortable? Can I get you anything while I'm here, like a magazine? I'm just going to open your curtain and wash my hands. After washing my hands, I'll think about the steps in my skill, make any corrections that need to be made, and then tell the evaluator my skill is done. All right, any questions? Any questions? Okay, we're going to watch the last video now, drainage bag, and this one goes really quick. Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to empty your urinary drainage bag. Is that okay? Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. For this skill, I'll need a barrier, which I'll place on the floor under the drainage bag. I'm going to need a set of gloves. And I'm going to need a triangular graduate container. I want to inspect the catheter tubing to make sure that it's coiled on the bed and the patient isn't lying on it and it's not kinked, but also that it's not hanging near the floor where somebody might get their feet tangled up in it and trip or accidentally rip the catheter out. This catheter looks like it's in the appropriate position. We'll now remove the port from its protective sleeve on the bag. Sliding the valve to the side will open the port. We can now position this open port over the graduated container and tilt the bag slightly to the side to allow the contents to drain into the graduated container. While doing so, we want to be careful not to allow that port to touch any other surface. Once the urine bag has been emptied, we'll slide the port back to the side to close it and very carefully insert it back into its protective sleeve. We want to make sure that the bag is hanging on a non-movable part of the bed and it's not touching the floor. We can now fold the chucks over the graduate container for safe and secure transport to the patient's bathroom. Once we're at the patient's bathroom, we're going to set the graduate container down on a barrier on a flat surface and position it so that we can read it. We need to be at eye level, and we're going to round to the nearest line, either up or down. You can see that the urine in this container is nearest to the mark of 425, so the amount that we will document is 425 milliliters or cc's. Once we've measured it on a barrier on a flat surface at eye level, we can now empty the urinary graduate container. We'll throw the barrier away, open up the toilet, and we're going to dump the contents of the graduate container into the toilet. Now we're going to rinse the graduate container. We'll deposit the rinse water into the toilet as well. Now we can clean. After dumping the rinse water into the toilet, we'll set it down, use a paper towel to pick it up, paper towel to dry the outside, a paper towel to dry the inside, and we'll discard this, and then one for the drawer. We're going to place the graduate container in the bottom drawer and close the drawer with a paper towel. Okay, now I'll throw the paper towels away and remove my gloves. We'll throw those away as well. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? A magazine, perhaps? You have your call light there. If you should need anything at all, please feel free to let me know. I'm going to open your curtain, wash my hands, and document my skill. Thank you. After washing my hands, I'll document on the intake and output sheet that the evaluator gives me. I'm going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. After documenting, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions? Thank you, Caitlin. Okay, so here's another one. Razor says, good morning. I just wanted to stop by and let Patty know that I passed my CNA exam because of this channel. Congratulations. Amazing job. And Caitlin, can you put the other one up too, please? The question. How long does it take to get a call after you apply to do the CNA exam? So I wanted to talk about this one real quick. Maureen, you're not going to get a call. Prometric does not call. You'll get an email that has your test date. So the process is you do your background check. You have to have a background check on file. Then you apply for the test. Once you've applied for the test, you will get an email within 1 to 3 days. You want to make sure it says application status complete. That means nothing is missing and they found your background check. Once you get that email, about 7 to 10 days later, you're going to get another email from Prometric that gives you your test date. And then you just go attend the test at the test center on that date.
And you said you just need 2 forms. You can do it a debit card and a license.
Right. 2 forms of ID. One has to have a photo non-expired. The other has to have a signature. Okay. Questions on that?
We bring that on the exam day, our license, and what else?
Yeah, you have to have 2 forms of ID that prove you are you on the testing day.
Like a credit card? And
So a photo ID
okay.
and something with a signature. So it could be a credit card, a
Social
library
card.
card, a social security card. Yep, any of those.
All right, cool.
It has nothing to do with the testing, but the fingerprint background, does it show a receipt after you paid for the
It should, yes. It should send a receipt to your email, actually. Okay. All right. So the last skill that we have to learn is one that we didn't get to earlier in the program, and that is range of motion shoulder. So if you look on page 76 and 77 of your skills book, and I don't have any slides on this, but 76 or 77 on your skills book, this is the last skill that we're going to learn, range of motion, shoulder. Do you guys remember the range of motions we've learned so far? Hip, knee, and ankle, elbow, wrist,
Yep.
right? So with range of motion, we read the care plan and we do exactly what it says. So this care plan tells us to provide the following range of motions to the patient's, I think it's right shoulder. Is it right shoulder? Left shoulder, flexion, extension, and abduction, adduction. So remember, flexion extension is up, down, abduction, and adduction is side to side. So we're going to, it's left shoulder. So we're going to take that arm up and down. The care plan tells us how many times. In this case, it's 3. 1, 2, 3. And then we're going to bring it out side to side. 1, 2, 3.
So pretty much the same thing as an arm.
Right. So we're going to move slowly. We're going to return to start to do a full range of motion. We're going to monitor for pain. We're going to keep our patient informed about what we're doing. And we're going to support from below at the joints. That's the skill. Do an opening in front of it, closing behind it, and that's the entire skill. So I'm going to show you this one, the video, because it has good close-ups from an overhead view, which will help you see especially the difference between the flexion extension and the abduction adduction. So let me show you this, and then we'll take a break, and the rest of the class will be practice.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
I'm great. I need to do some exercises on your left shoulder. Is that okay?
Yes.
I'm going to close your curtain and go wash my hands. I'll be right back.
Okay.
Okay, I'm going to do a series of exercises. We're going to repeat each one 3 times each. The first one's going to be a flexion extension where I raise your arm over your head and back down to the bed, and we'll do that 3 times. Is that okay?
Okay.
I'll do all the work. All you have to do is let me know if there's any pain or discomfort.
Okay.
I'll stretch your arm out here to start. So we're going to raise it above your head and back down to the bed 3 times.
Okay.
Supporting at both joints. We're going to go all the way up and all the way back down. Feel okay?
Yes.
Any pain?
No.
We're going to go up again and all the way back down. That's 2. 1 more. Up and all the way back down. That's 3. Feel okay?
Yes.
All right, your next exercise is an abduction, adduction. We're going to swing your arm to the side and back in. We'll do this 3 times.
Okay.
Like you're making a snow angel.
Okay.
So we're going to go all the way up and all the way back down. That's 1. All the way up and all the way back down. That's 2. All the way up. Feel okay?
Mm-hmm.
And all the way back down. That's 3. Are you comfortable?
Yes.
Can I get you anything, such as a magazine?
No. No.
Okay, your environment is clean. Here's your call light. If you should need anything at all, please let me know. I'll go ahead and open your curtain. And there's nothing else that you need?
No, ma'am.
Okay, I'm going to go wash my hands. Thank you.
Thank you.
After washing my hands, I'll review all the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right. Huh?
So I hope I get that.
Oh, I know. If I got to pick my skills, I would absolutely pick range of motion. Absolutely. All right. Any questions on what we've learned? Okay. The class itself, all of the learning is now done. There's nothing more to learn. So the rest of today is practice. On Wednesday, please bring your yellow books back. And I'm going to give you your review sheets. Bring your yellow books back. You'll keep your white books forever. But bring your yellow books back. We will take a class photo on Wednesday that goes onto social media. You can share it, download it, whatever you want to do with it. And I am going to go over, we still have some things to go over on Wednesday for graduation. We're going to talk about how to find a job in healthcare because it's different than other agencies, how to renew your certification to keep it active, what continuing education is and how to get it. We're also going to go over, this is probably the one reason you absolutely want to come to class. Do you know that part of the interview where they ask you, tell me a little bit about yourself, and everybody freezes?
Yes.
Mm-hmm.
Yeah, I'm going to, the review sheet, I'm going to go over it in class, and the review sheet that you're going to get in class on Wednesday is going to help you craft your tell me a little bit about yourself that will absolutely nail the interview. There's a formula. There's an actual formula that you can use to craft a quick paragraph, like 3 sentences, that helps you nail any interview. So you're definitely going to want to come for that because that's going to help you not just with healthcare, but everything else that you do. If you want to go to work in aerospace or wherever, I'm going to teach you how to nail that interview. Okay, so that's one thing you want to come to class for. So Wednesday is our last class. Make sure you're in uniform so that we can take a class photo. And you will have some practice time in class on Wednesday as well. Okay, so any questions before we sign off? Any questions? I'm printing your review sheet from today. Finally got them all done, and I got them, they're actually being printed at the printer, but that'll be for the next class, not for you guys, unfortunately.
For the exam, there's one that on the computer it can read to you. Like,
Yes, it's oral is what you want to choose. Yeah, that lets the computer read the test question and answer choices to you. There's no extra cost for that. You just have to check off the right.
you know how you always talk during your exam, well, not exam, your skills. Do we have to talk and like you do?
So that's a very good question that comes up quite often. Okay, do I have to say everything you say when I'm doing the skills? And the answer is no, you're not graded on saying everything that I say, but Who do you think needs to know what you're doing?
The patient.
The patient. The more information you give the patient, the more compliant they become.
More comfortable they are too.
Absolutely. Because if you're touching somebody without talking to them, it's awkward. And they may not understand what you have in mind. So I tell the patient everything. If my hands are going to touch that patient, they better know what I'm doing, why I'm doing it, and how I'm going to do it. Otherwise, I'm not helping them. I'm being them.
It's always about the patient.
Yeah, it's always about the patient. So the more information you give the patient, the better off you are. And that's what I said on week 1. If you can make that switch in your brain that the test isn't about you, the test is about the patient. If you can manage to make that change in your mind, and it's hard, I get it, I know it's hard, but if you are successful at doing that, at focusing everything on the patient, not on you, you will ace your test. Okay.
I think it helps you remember your
It does.
steps, too, as
It
you're
does.
saying them.
Yeah,
I notice when I
definitely.
practice at home, like me doing it, it's like, okay, I check.
That's right. It'll help you learn those steps as well. We've had literally thousands of students that have taken our class or watched our videos or taken our online course, thousands. And I hear back from a lot of them, and they all tell me the same thing. When I was in the testing center, I heard your voice. I heard you walking me through the steps. You will hear me. If you just say what I say, you'll be fine. Just be me. Just be me. All right. Any other questions? Those of you that are getting ready to test, good luck. Best of luck to you. I hope you tune in on Wednesday. We're going to go over some very useful information about continuing education, how to keep your certification, and how to ace those interviews. So I hope you join us for that. Remember, next Tuesday, a week from tomorrow, is our live game show. Make sure you tune in for that as well. So we're going to go ahead and log off for today. We're going on break, and then they're going to practice. So until next time, happy caregiving. Bye.